I have the honorable task to be the caboose for this wonderful meeting. And fortunately for you and for me, I think this is a very pertinent topic. It's a topic that is probably happening in your intensive care unit. If not, you should be asking, why aren't we doing plasmapheresis in critically ill patients? Because I think that it has been shown to be effective. There is really good guidelines, and in my opinion, there is absolutely a right approach and a wrong approach. And hopefully over the coming 15, 20 minutes or so, I could share with you kind of my thoughts about it and give you guys some tools to go back to your intensive care unit. So what we're going to talk about today is we're going to review what TPE is, plasmapheresis, or therapeutic plasma exchange. I'll use those names interchangeably. Discuss the potential risks of TPE. Discuss the evidence and the categories and a resource for you to have so that you can make good decisions about which patients should be getting this therapy and which should not. Review briefly the Category 1 and Category 2 indications. Category 1, I describe as you should be doing it, or you're going to be sitting, on the stand one day. People are going to ask you, why aren't you doing this therapy? Because there's guidelines that show that absolutely it's beneficial, it's the right thing to do. Category 2, there's sufficient evidence that suggests that in combination with other things, you should be considering doing plasmapheresis. We're going to also examine the important considerations before starting, and then go through some of the technical aspects of TPE. So this is a broad conversation. I'm not going to go into great detail. I don't have many, slides on the physiology of these diseases, but it's really designed to just kind of give people a broad idea so that they can expand their insights and knowledge from this talk once they continue. So we all learned this in medical school, the blood components. There's red cells that are the heaviest, and so if you put them in a centrifuge, they're going to go to the bottom. There's the buffy coat with white cells and platelets and other things. And then there's the plasma, which I describe to my patients. It's kind of like the broth of the chicken soup. So you're not really, you don't have the red cells like the carrots, but it's just all the stuff that's in the juice of the plasma. And those things, there's certain things that happen in acute illness where, if you can remove those, if you can remove the things that are sitting in the plasma that are causing disease, then maybe you can improve your patient's outcomes. So what apheresis is, it's really kind of the removal or separation and removal of any of these blood components. And so if you talk about red cell pheresis, that's done commonly in sickle cell disease, where you remove the bad red cells and replace them with fresh, good red cells. You can do white cell collections, and you can remove it for patients with leukemia, for example. That's called leukapheresis. You can remove LDL pheresis and remove cholesterol with it. We're going to talk about you can remove platelets. This is how donation of platelets is done. They do platelet pheresis. But mostly what we're going to talk about here is really plasmapheresis, the removal of the chicken broth, so to speak. So what you do with plasma exchange is you rapidly, over a period of about 90 minutes up to 2 hours, effectively remove everything that's in the plasma. And the things that we think about removing that are potentially harmful are antibodies, perhaps complement components that are driving the complement cascade, perhaps cytokines that are causing the SIRS picture, for example. It's not dialysis. It's not dialysis mainly because what you're removing is really you're removing everything. You're removing the albumin, the immunoglobulins, all the big particles that are floating around are what you're removing, and you don't remove the protein-based particles when you're doing dialysis. You're only removing kind of the tiny molecules. So, and very importantly, it's important as a consultant, and whether you are the person who's performing the pheresis or you're the person who's in charge of the entire patient, it's really important to recognize that simply washing away and removing the plasma and replacing it with fresh plasma isn't going to halt the underlying process. And so absolutely positively, you have to think about this in two ways. One is, kind of the janitorial duties of mopping up and getting rid of all the stuff that shouldn't be there, but you must absolutely stop the underlying process. And you got to think about what is the process happening, and you have to attack it on both fronts. Like any other procedure, when we consider who should get plasmapheresis, we have to balance the potential risks and benefits of the procedure. And fortunately, there is really this wonderful group that is headed by the Apheresis, the American Society for Apheresis. This has now been published, and it's now on their 7th special issue. So if you're going to have one document in your arsenal that helps you perform plasmapheresis, this is it. They come out with this every 2-3 years. I know where to find it. All my colleagues know where to find it. And it's a really wonderful document that in a really quick period of time can really guide you through what to do in situations where you absolutely know that you should be doing. And it can also give you some arsenal when a consultant maybe asks us to perform what I call psychopheresis, where people say, hey, I don't know what else to do, and I'm just hoping that this is going to help. Well, there's documents that basically you could pull out and in really brief period of time say, hey, look, we're not going to do this for lupus because lupus nephritis has been looked at in apheresis in multiple patients, and there's plenty of data that says that it doesn't help for lupus nephritis, for example. So these guidelines are wonderful. Highly recommend that you get access to them. And they talk about categories. I mentioned, category 1, which are disorders which apheresis is accepted as first-line therapy. And again, this is where you do not want to, stand in court and someone ask you, why didn't you not do plasmapheresis for this category 1 indication? Category 2 are disorders of which apheresis is accepted as second-line therapy with a knowledge that you're also doing other treatments in conjunction. Category 3 is where there's maybe a couple of cases, but there's not really great evidence one way or the other. And category 4 is basically saying, this has been done. People have looked at this. There's plenty of data. Category 4 is kind of where you should say, I'm drawing the line. This has been proven not to help in this situation. And so examples of some category 1 indications, I don't have time to go through them all, but certainly, Guillain-Barré, acute liver failure is one that I'll talk mention for this audience because I think it's pertinent, and there's a recent trial that kind of really suggests that perhaps plasmapheresis is important in acute liver failure. Certainly thrombotic thrombocytopenia purpura is absolutely going to be seen in your ICUs and is absolutely an indicated reason. Other things that, myasthenia grava, kidney transplant, humoral rejection, and you can read some of the others there as well. So this is an example of a guideline. I picked TTP here. Again, and some of the things that you could see here is, it'll tell you the category, it'll tell you how often you should do it, it'll tell you a brief description of the disease, it'll tell you the current management, it'll guide you to say, okay, well, should you be doing this every day, and what are you looking for to say, okay, now we should be backing off. So it's really, and again, you can't find a better one-page this is what to do for apheresis for TTP, then I think this guideline. It gives you the rationale, it gives you some technical notes, and again, it tells you specifically, whether you should be using plasma or if you should be using FFP to replace it, and I'll talk about the reasons for that a little bit more. Talks about the duration and discontinuation. And so every disease that people have looked at or have asked, should we do apheresis on, you have this, one-page guideline with plenty of references to kind of help you for further reading. So I do want to talk about two things. One is high volume plasma exchange in patients with acute liver failure. And this is a study that took a long time to conduct. It was recently published. And what they did is basically there was a randomized clinical trial of 92 patients who received high volume plasma. And they use a high volume, and meaning that it was like about 8 to 15% of their total body weight, which is probably higher than anything that I've ever done. So it's probably about 2-3 times higher the exchange that normally is used. And their primary outcome and there was 90 patients who just received standard medical therapy without high volume plasma exchange. The primary outcome was liver transplant-free survival, and secondary outcomes were survival after liver transplant. And so here's what the study shows. If in patients who received the high-volume plasma plus standard therapy, you could see an improvement in survival. And a lot of this was due to the fact that in the high plasma exchange, they were able to get a transplant. So essentially what this says is that if you do this high volume exchange, patient's going to live longer. They're not going to live without a liver transplant, but it potentially gives them extra time so that they can get kind of a transplant comes their way. So I recommend that you read through this publication, and I think it is an alternative that we have now for patients who come in with really severe liver failure awaiting transplant. The other one I think is pertinent for this room is thrombocytopenia-associated multi-organ failure, and it's come from the pediatric literature, and there's growing support for it. TAMOF is characterized by essentially thrombocytopenia in context of severe multi-organ failure in critically ill patients, and it's seen when you have platelet counts that are dropping, and when I've seen it, they're dropping into the 30s and 40s in context of sepsis. When you look at autopsy studies of patients who have TAMOF, what you essentially see is a thrombotic microangiopathy with consumption and thrombus in major organ systems. And part of the reason that we end up doing this many times is because we know that that TAMOF has a very, very high probability of mortality with standard of care. And so this is the randomized clinical trial. This is a trial that unfortunately was stopped early because everybody who was randomized to the group to get plasmapheresis survived. And so it was stopped early, and now the criticism is, well, we shouldn't have stopped it early. I think that the people who were doing it were having a hard time saying, okay, well, I really believe in this therapy, but I'm no longer going to, give a family placebo. And so that was part of the reason that it was halted. But again, all 5 patients that were in this randomized trial survived despite them having really severe sepsis and probability of death that was over 60-70%. And you can see here, you can see here the PLOD scores, which are kind of like an Apache or a SOFA score that we use in pediatrics. But you can see that in the patients who receive plasmapheresis, these scores just kind of abruptly dropped. And so I've seen patients where we do plasmapheresis for TAMOF, and I was sitting around after a couple days, and I'm like, nothing really happened here. Alternatively, I've seen patients where absolutely positively, 1 hour after stopping, plasmapheresis or after completing the therapy, you see their pressors come down really sharply, and they look really like very normal patients. 24 hours right before the next therapy, they're back on their pressors, and again, you do the pheresis, and their hemodynamics improve drastically. So I do believe that there is some patients where this is helpful, probably not all of them. So shifting gears a little, just for the sake of time, apheresis complications are not very common, but you have to be alert for them, especially in the ICU. You can see here, this is a study in ICU patients, and the most common side effect was hypotension, and that was about 8%. There was others like chills and rash. And really, when you think about complications with pheresis, I think about them in several categories. Number one, you can certainly have access complications Two, you can have access complications when you're giving plasma for any reasons, like allergic reactions, things of that way. You can have metabolic issues related to the anticoagulation if you're using citrate, for example. And the biggest one that I worry about is really the unwanted removal of the drugs that you're giving. Again, you're removing everything that's in the plasma. So if you have a nice, cephalosporin in there that's treating your sepsis, you just got to be really conscious of it and make sure that you're aggressive in returning that back once the plasmapheresis is finished. Transfusion reactions, it's really critical when you're performing plasmapheresis to know that you have a very high risk for hypocalcemia. One of the reasons for it is because in plasma, the reason that when it comes to you, it's not clotted off because it's got tons of components is because there's a lot of citrate in it. It's actually, by volume, makes up maybe 15% of the bag. Okay, so it's a very, very high concentration of citrate, and you just have to recognize that as you're performing your therapy and you give back calcium, you give calcium to the patient during these initiations, especially when you're using FFP, it's extremely important that you're mindful of that. You also have a risk for bleeding. Bleeding could be because of, number one, because you are removing some platelets. Number two is because you're removing the good stuff too. So you're removing the coagulation factors that are preventing you from bleeding out. And so if you're going to be doing plasmapheresis, and especially if you're going to do it kind of on a daily basis, you're going to end up really depleting your coagulation factors unless you're replacing them with plasma. I'm going to talk a little bit more about the decisions between how to choose whether you should use albumin versus plasma coming forward, but just important to recognize that if you're not using plasma and you're doing multiple episodes with just albumin, you run the risk of having bleeding problems. So the metabolic complications when using albumin for replacement is hypocalcemia. We know that calcium, binds to albumin. So if you give lots of albumin to your patient, your patient's going to become hypocalcemic. In our program, and there's been studies to look at the safety of this, we actually put calcium into our albumin bottles, and we have a nice formula to kind of tell us how much to give. I believe it's 1 ml per vial of 10% calcium that we give, and that prevents the hypocalcemia. Again, if you're using FFP, you run the risk of hypocalcemia because FFP contains tons of citrate. And you can develop metabolic alkalosis, much like we have learned about citrate anticoagulation on CRT. And I've mentioned, the drug removal as a big problem. It's always best to just plan to give the antibiotic or the medicine right after you finish the pheresis. That's the easiest way to go if you have a once-a-day medicine. If you have a medicine you're giving 3, 4, 5 times a day, it probably doesn't matter much, but you got to be cognizant of it. Otherwise, you're going to be stealing these important drugs to your patient. And there's so I've kind of said some kind of theoretical stuff. I'm going to go ahead and jump into, okay, well, actually, what is it that we're actually doing? How do we actually do this? And so the steps to the procedure, I think start with just, turning on your brain and having a conversation with your families and having a conversation with the rest of the team. Because especially if you're not doing kind of a class 1 indication, when you start going to the class 2s and class 3s, many times you're going to be doing this and you're going to potentially be left in a place where you're not sure if this is helping, you're not sure if you should stop, you're not sure if you should continue. So having a conversation up front is really important so that everybody understands what the plan is, so that everybody understands what biomarkers you may be watching for to say, okay, we're getting better, how many therapies we're going to give before we kind of say, it doesn't really work. So it's really important to develop a plan before the first treatment. And you have to develop things like where you're going to do it. You have to think about how you're going to deal with the calcium, whether you're going to put it in the albumin bottles, are you going to give calcium through a replacement line, and then we talked about medications. There's 2 types of plasmapheresis that you can do. The first I'll talk about is centrifugal TPE. Basically what happens is you get the blood out of the patient's body, you put it into this big, huge centrifuge, it spins it around real fast and separates the blood so that the red cells are kind of on the outer area and then the plasma is kind of on the inner area. And you have these little chambers here that kind of are like railroad tracks that kind of divert different cell lines to go to the left or to go to the right. And it's essentially based on, again, the gravity that the centrifuge is causing. And separation can be done that way. Again, you have the blood going in one way, the red cells kind of returning back to the other patient the other way, and then you take the plasma, which you end up throwing out into the garbage, and then you, on the way back, before you mix up the fresh plasma with the red cells and the good stuff, and it's essentially a relatively simple concept. The issues with centrifuge or TPE is it removes all the non-solid elements out of the blood. Okay, so the clearance or the sieving coefficient is essentially 1 because whatever is in the plasma, you're going to be kicking out at 100%. Most protocols call for citrate-based anticoagulation with changes on the machine that reflect kind of the blood flow to the citrate ratio to avoid kind of giving too much citrate and to prevent your circuit from clotting. The second concept is membrane TPE, and we've heard a lot about different cutoff membranes. Essentially, a membrane TPE is using a really large hole, and so you have a massive hole that allows things like albumin and immunoglobulins and things of that nature, but keeps back cellular elements like red blood cells from being transferred across the membrane. So when you do membrane TPE, it's dependent on multiple things: the blood flow, the hematocrit, the transmembrane pressures, the filters. It's separated according to molecular side, and the pores are about 0.2 micromole in diameter, which is essentially 3 times larger than your typical dialysis filter. This is a study that looked at kind of differences in the sieving coefficients with membrane TPE. You could see that it's not all the way to 1 on some things, but you're getting pretty close. So it's 90 to 100% the sieving coefficient. So to me, membrane TPE and centrifuge TPE are doing almost the same, or 90% of the same, as far as the clearance goes. The prescription. It's generally you need a little bit less flow. If you have lower blood flow, it's just going to take you a little bit longer to get the job done. So you can have slightly smaller catheters. Some people try to use large eye-bore IVs, which you can do it if you're going to be doing a kind of a therapy once a month. But most of these patients in the ICU are getting repeated therapies. So essentially, you're using the same type of catheter that you would use for other extracorporeal therapies. This is a nice figure that basically show the percent of plasma removal that happens based on the volume exchanges. And so if you do one volume exchange, you're essentially removing somewhere about 60%. And so most people use somewhere between 1 and 1.5 of the extracorporeal therapies. Again, one exchange removes about 63%. 1.5 removes 72%. If you go much higher than that, you're really not getting much benefit, and you're potentially causing more risk by removing some of the good things that you're trying to remove. We do need multiple exchanges because, again, you're not getting 100%, and there's kind of this washout where once you remove the plasma, some of the bad things that are kind of living in your tissues will kind of come into the plasma. So you do need increasing numbers. You do see kind of if you were to measure an antibody that you're concerned about when you finish, that you will have a rebound after that. If you're using smaller patients, please consult with someone that knows how to do blood primes. I won't go much into that, but certainly you can have, if you're less than 10% of your extracorporeal volume, you're okay. If you're a lot above that, you may need to get in trouble without a blood prime. I mentioned the 2 types of replacement. Certainly if you're just wanting to remove something, then albumin is essentially okay. If you have a disease where not only do you want to remove something, but you want to give something back, TTP being a great example of that, that you want to give back some of the Adams T13 protein, you're going to be using all FFP. Again, if you're going to be looking or preventing bleeding, in our program we follow the fibrinogen level, and if it starts to get low, then we will use a plasma as replacement. I'm not going to go into great detail on this just for the sake of time, but you can use heparin, you can use citrate as well. We used a citrate protocol that's very familiar to us. It's very similar to what we do in CRT. We monitor the patient's ionized calcium. If the patient's blood flow is 100, we use ACDA at 1.5 times the blood flow, and then we use calcium at 0.4 times the citrate. Again, there's other protocols out there. This is how we do it with CRT. This is how we do it when we use albumin. Our approach, if we're using FFP, is to simply just give more calcium because we may get hypocalcemic and actually use less citrate. And so we use the blood flow equals to the citrate equals to the calcium, which works well for us, and it's pretty simple to remember. So as my last slide, so in summary, TPE is a type of apheresis which can be performed using both centrifugal and membrane machines. Before the first TPE, communicate between primary team and the family is critical so that everybody understands the potential benefits and risk, as well as to determine what they will use as clinical response. And for the apheresis, access is always critical. You can use heparin and citrate. Remember that if you use FFP, you're going to drop if you're not using FFP, you're going to drop your fibrinogen. So use it if your fibrinogen is going to get low. And generally speaking, we use 1 to 1.5 volume exchanges. Thank you very much.